Hello everyone, I am Dr. Gaurav. I am an assistant professor in Department of Cardiology at UN Mehta Hospital. Uh, Today we are going to discuss an important aspect in intervention cardiology, that is ISR, that is in-stent restenosis after implantation of drug-eluting stent. Here we have a case, a 45-year-old gentleman presents with in-stent restenosis in LED stent after 5 years of drug-eluting stent implantation with typical angina and chest pain despite optimal medical therapy. So our discussion point would be what would be our approach in this case. So as you all know, in-stent restenosis or ISR is basically defined as gradual re-narrowing, that is more than 50% of a stented coronary artery segment or its edge, that is 5 mm segment adjacent to the stent. And we have a classification, that is Mehran system is a basically a morphological classification, and it was originally created for BMS ISR, but it has some prognostic value in terms of repeat revascularization in drug-eluting stent ISR also. So what would you do first in this case? So as you see, the 45-year-old male, and he had undergone angioplasty 5 years back with a drug-eluting stent. The first step would be to image first, either with the help of IVAS or OCT, to identify what is the cause of ISR, what is the mechanism of ISR. That is the great important in the management of this case. So image first. So IVAS can detect what is the problem with our stent, whether it is underexpanded or there is a neointimal hyperplasia or there is a edge restenosis or there is a strut fracture. OCT, due to its superior axial resolution, provides better image of vessel lumen interface, neointimal tissue, and stud distribution. So OCT is slightly better than IVAS for ISR evaluation. So what would be our treatment option? So once we have imaged the vessel, then what are the treatment options? The first option is COBA, age-old COBA, that is plain old balloon angioplasty, with or without cutting or scoring balloon. This is a age-old method, works well in if the ISR stent is under expanded. Otherwise, the problem with COBA is that there are higher chances of restenosis, and even the early lumen loss area is also great with COBA. So the good thing about COBA, it's a technically simple procedure, but the bad thing about it, higher chances of recurrent or repeat revascularization. What is the second option? Placement of another desk containing different drug. So if we have an ISR in a BMS stent, that is a non-drug-eluting stent, this is the first option. You place a stent which is a drug-eluting stent, but here we are dealing with a ISR in a DES. So placement of another DES, preferably with a different drug, and that is termed as a hetero-drug approach. The logical explanation for this is a different drug, a different polymer will help to prevent another ISR. So another upcoming treatment modality is DCB, that is a drug-coated balloon. It is very effective in treatment of both BMS and DES ISR, and it does not add additional layer of metal, and technically simple. So DCB is an upcoming treatment modality for DES ISR. And in selected cases where placement of another test is not possible or drug-coated balloon is not possible, then CABG is a viable alternative option. So we have 4 options for management of this case. The preferred one is placement of another dress containing different drug or DCB, and CABG in selected cases. So the take-home message from my side is that treatment of DES ISR is very challenging, and second generation DES or drug-coated balloon are best. And more than two metal stents in a repeated ISR lesion is likely to have a detrimental effect on long-term outcomes, and we should not go for another metal layer in such cases. And CBG in selected cases would works wonders. More studies and newer treatment options are needed for adult treatment of DES ISR. Oh, thank you.